شوفوه؟
ايه واضحة.
تمام.
واضح.
ممكن بعد حاول تشوف البول، حتى هي عملت سؤال قبل ما نبدأ نشوفه.
ما طلعلكش دكتور منصور؟
لا تو السلايد بتاع دكتور محمد واضحة، لكن عملت بول أنا أعتقد البول رقم 6. أو نقدر نعملوه حتى بعد، مش لما نحصل أكثر بارتيسيبنت نقدر نعملوه بعد المحاضرة، نعمله على الأقل السؤال الأخير.
ما شفت شيء، في حاجة طالعة.
لا جست سلايد يعني بتاعت الدكتور محمد الحاري، صحيح الكل يشوفها أعتقد.
لا أنا ما شفتش فيها.
ما تشوفيش في الايرون ديفيشنسي ايمرجنت ثيرابيوتيك تارجت ان هارت فيلير؟
لا شاشة سوداء ما في شيء.
غريبة نشوف فيها.
نشوف
اوكي تو طلعت تو شفتها.
should be okay. محمد حبيت نطمنك بس صاحبك اموره تمام 100%. كيفيات؟
صاحبي طبعا لا متواصل معي بارك الله فيك. لا تعب شويه في البدايه لكن شويه،
لكن الحمد لله تمام.
لا بارك الله.
كلمته يوم قلت له شن داير، قال لي متغدي عصبان متعشي كسكسي، قلت له مليح بكره ماشي مع الريكومنديشن بتاع
لا يا راجل انت معفنها يا راجل. في هذاك اليوم صار واحد قال لي في عزومه يا راجل ايش درنا نخرفوا هذا صح. هي مشكله الراجل هذا سوبر سوشيال يعني ما والله كان يقدم انتخابات لم يحول رئيس البلاد.
دكتور محمد نحكي لكم قصه هيك على الموضوع هذا بتاع الاكل فاني شويه. عندي صديقي لما كنت نشتغل في مركز طبي في السي سي يو، في واحد من الدكاتره اللي معانا عنده عمه جايب ستمي في الليل، جاي مخر هيك باهي، فالهم اعطيناه ترومبوليتيك واحد. مشي قال لي بالله عليكم، قال لي عم انا جعان، قال لي شويه. مشي دكتور هو مشي طلع في كافتيريا قدام الطبي، جاب له همبرجر وشيش بيبسي وجاب لي يتعشى بها. يعني قلت له رجل ستمي والدكتور معنا في العنايه، بدل ما تقول له اكل صحي مش عارف ايه، جايب له همبرجر. فكرتي تو انت بالقصه هي بتاعك.
واحد انا خاش الايميل فتحته اكيد فتحته استمي المهم تريتمنت وكذا، فجاي نقول لك قلت اسمع راو سموكينج هذا خلاص انساه. قال لي ضروري راو قاعد فريش قاعد الدنيا قاعد الدنيا قال لي ضروري نوقف. ما مش حتى يقول باهي ولا تنحاول.
تفكر
اخوي ايمن ممكن تعمل تسجيل كاحتياط ولا لايف ستريم معنا؟
لا انا لايف ستريم ما نقدرش ندير الزوز، لازم حد يشوف
انا تو
يدير على الجهاز نتاعه.
تو بندير نبدا تسجيل، واللايف ستريم انت قلت لي حيسجل اوتوماتيك صحيح؟
ايه اللايف ستريم تمام. تو احنا اوريدي على اليوتيوب، انا تو كيف بالضبط حطيت على الفيس بتاع الجمعيه، وتو بنحطه على بتاع الليبيان كارسايت ونبدا. يعني تو اقل من دقيقه امور تمام، تقدروا تبدوا انتم. تنقول لك
انا بعثت ريكوست للريكوردينج.
ايه لحظه بس خلاص.
قدرت في امكانيه تحط البول يا ايمن؟
لحظه بس نشوفها.
تلقاها ممكن البول نمبر 6 تنزل مع البولينج نمبر 6 اللي ما قبل الاخير. انا حطيت ما قبل الاخير والاخير اللي هو ما قبل المحاضره ما بعد المحاضره، سؤال واحد لكل واحد يعني.
خلاص تو قبل المحاضره خلينا نشوف طلع توها.
مشيت رقم 6 الثانيه اي سي جي مش عارف في تاك مش عارف شنو حاجه هيك.
لحظه بس في سؤال ندير لانش شوفوا ترى تو. المهم احنا على الموجودين.
لا مش هذا،
لا هذا مش هذا.
المحاضره اللي فاتت اي سي جي
ضفت يمكن ضفت حاجه جديده. خلاص لحظه بس. خلاص I think found it.
تلقاها اعتقد نمبر 6.
لقيتها
ما قبل الاخير.
ما بيش يطلع لي. خلاص لحظه. خلاص تبي نحطوه توا يعني قبل ما تبدا التسجيل
واحد
ولا غندير تيست بس؟
لا واحد.
لا خلاص.
للاودينس يشوف الاودينس ريسبونس بيفور اند افتر.
قصدي تبي قبل ما نبدا توا تقديم محاضره ولا اول ما تبدا المحاضره نفتحها؟
لا اول ما تبدا المحاضره نقدم المحاضرين ونبدا المحاضره بنبدا بالبول وبعدها الدكتور محمد يبدا بالمحاضره.
خلاص باش نديروا تيست بنحطها تشوفوه او لا. باهي ما تجاوبوش. واضح؟
That's correct. ايوه واضح.
خلاص تمام. ان شاء الله انت بتبدا المحاضره او ما تقول بول حنفتح ان شاء الله.
والتسجيل بادي تسجيل صحيح؟
ايه
باي خلاص نتوكل على الله ان شاء الله.
توكل على الله. عندي ميوت للكل بس من يقدر يسجل محاضره على جهازه؟
انا طلبت بعثت ريكوست التسجيل مش عارف جاك او ما جاكش يعني.
جايبك سبت ده
جاي بكري ويقارد
يعني تقدر تسجل يا منصور. ابدا ريكوردينج
يعني انا المفروض
توكل على الله. ممتاز. هي
سامحوني انا غير فقدت الصوت يعني. خلاص نتوكل على الله باذن الله تعالى. السلام عليكم ورحمه الله تعالى وبركاته. Welcome all to our heart failure lecture series. Our speaker today, Dr. Mohamed El-Harari, who is a consultant cardiologist with interest in heart failure at Tawam Hospital, United Arab Emirates. He also serves as the chair of the heart failure group at the Emirati Cardiac Society. The topic today is iron deficiency and emerging therapeutic target in heart failure. On the expert panel, we have Dr. Ilham Al-Gaddafi from Tripoli Medical Center, Libya, Dr. Mohamed Al-Hammali, Misrata, Libya, Dr. Ayman Smear, Cretan University, USA. Dr. Mohamed El-Harari, the stage is yours.
Assalamu alaikum. Want to do the poll now or later? Questions? No? Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. It's really a pleasure and honor for me to be here, and really I'm grateful and thankful to my colleague in the Libyan Cardiac Society and for inviting me to give this talk, which is really a challenging in itself to talk about iron deficiency. Is it an emerging therapeutic option in heart failure management? My task tonight is to convince you that's the case. And that's what I practice. So see whether I can convince you to do this. There's a broad question here. I don't know if you can see it, and the idea whether to answer this question before or after the talk. And the question states: do you routinely investigate your heart failure patient for iron deficiency? Yes or no? So I think if you could answer this now, and then we'll proceed with the talk. So I'll just go ahead. Okay, these are my disclosures. Okay, so the objective of this talk is to talk about the iron deficiency itself, anemia, its definition, the difference between what they call absolute and functional iron deficiency, the pathophysiology of iron deficiency in heart failure, the prevalence of iron deficiency in heart failure, And following that, the impact of iron deficiency on the morbidity and mortality in heart failure. We just go like a sort of story thing and just from one step to the other. So following that, we'll talk about the evolution of the management of iron deficient heart failure over the last 2 decades, from blood transfusion, oral iron, erythropoietin, and then finishing with the IV iron carbohydrate complexes. And then really, because that's the real or main treatment that we currently recommended for iron deficiency anemia is the IV iron carbohydrate complexes. And what is the evidence that this IV iron works, and what's the mechanism of their work? And then we specifically will talk a lot about ferric carboxyl maltose, which this is the most studied recently. Its effect on quality of life, readmission, heart failure. Specifically will highlight the FAIR heart failure and the confirmed heart failure trials. And from that, we'll talk about the use of ferric carboxyl maltose in the pre-discharge for patients with admitted acute decompensated heart failure, highlighting the FIRM acute heart failure trial. And from that, we'll talk about the long-term use of IV iron in iron deficiency anemia heart failure patients, the recent Ironman study. And then we'll try to summarize all the evidence in the recent meta-analysis of all the trials in the IV iron in iron deficiency anemia heart failure. And then we'll finish off sort of by what the current guidelines say on the use of IV iron for heart failure patient with iron deficiency. And the ongoing study or studies currently going on with the IV iron in heart failure with iron deficiency. Now, as with many things in our body, there's always a sweet spot for things. So for your potassium, for your sugar, for your maybe blood pressure. So there's a range or level where you are perfect, you're fine. Above which you don't do too well, below which you don't do too well, whether it's potassium, sugar, whatever. That's also applied to your hemoglobin. So believe it or not, the ideal hemoglobin for man is 15, for female is 13, below which and above which there's increased mortality. That's reality. That's true. What causes anemia in heart failure? So many mechanisms. Anemia of chronic illness, drug-related, malnutrition, blood loss, associated conditions that cause anemia like renal dysfunction, etc., etc. Now, being whatever specialized or interested or whatever in any field in medicine or others, it actually leads you to have to learn about other things. And we had to learn more about lipids with the use of all these lipid agents. We had to learn more about diabetes because of the SGLT2 inhibitor GLP-1. Similar thing now with the iron deficiency. So we have to go back to our basic and try to understand a little bit about iron. And that's I'm not a hematologist, so what I'm saying may not maybe rubbish or no basis, but as far as I can tell, I can find out, can understand. So basically the iron in your body, it has always in a recycling state between a functional and a non-functional. Most of our iron is present in the hemoglobin, which is a part of the function. 60-70% of your iron body is actually the hemoglobin. So it actually, the job of it is to carry oxygen throughout the body, which we all understand, we know. But 10% of this iron, functional iron, actually stored it is a part of the myoglobin, which stores oxygen inside muscle and tissue. You got oxygen stored inside the muscle tissues. You get oxygen in your blood, part of hemoglobin. And there's only 1% is part of the metabolic enzymes or enzymes that's carry the function of your body. So only 1% is functioning, and the majority actually carried out in the hemoglobin. Some is stored in the myoglobin as oxygen, not stored, storing oxygen from myoglobin. It's all functional iron. The stored iron that we know, it is in the form of ferritin, which is mostly in the liver and macrophages. So this is about 20 to 30% of our iron is actually stored. And that's what we measure when we look for anemia, look for the serum ferritin, the storage of our iron. And actually only 0.2% actually is transport in the blood going around between various parts as part of the transferrin. And that's what we measure when you say transferrin saturation. As you said, if your transferrin is saturated, means you got enough iron in your body going around your body. And if transferrin saturation is low, that means you don't have enough iron going around in your body. So we measure the serum ferritin to assist our storage, and we measure the transferrin saturation in addition to serum iron. So anemia, actually iron deficiency, you either have what's called absolute iron deficiency, that you have a low storage, you have low serum ferritin because you are losing blood, because you're not eating enough or not absorbing enough. This is true absolute iron deficiency because of low ferritin, low storage. But we have to remind ourselves and remember there is particularly in chronic illnesses, what's called functional iron deficiency. You have enough storage, you got plenty of ferritin, but actually it's not working, it's not released. It is not, body is not making use of it. And we'll try to go through why that happens. And this is WHO definition of iron deficiency that's been used in all the iron deficiency study in heart failure. This is standard. So obviously in the healthy people, which doesn't apply to heart failure. So if you are healthy, you have to have a low ferritin less than 20 or 30 before we label you as iron deficiency. But in chronic illness, this is a completely different story. So in the people we deal with, the definition of absolute iron deficiency, i.e. you have a low storage, you have low iron in your body, low ferritin. If your ferritin less than 100, then you have absolute iron deficiency. So we don't use the 20-30. If your ferritin is 90, then you have iron deficiency. You are losing iron, or you're losing blood, or you're not eating well, whatever. So you have low storage. But also still in chronic illness, because the ferritin is acute phase reactant, it goes up, the level it goes up. So you can still have what you call functional iron deficiency, even with a high serum ferritin, because not enough of your iron actually circulating in blood to be distributed, which is measured by low transferrin saturation, less than 20%. So that's what is functional iron deficiency. So you could be in heart failure or any chronic illness, you can have either absolute iron deficiency. If your serum ferritin is less than 100, you have iron deficiency. But you still be able to have iron deficiency even if your serum ferritin above that, even up 300 or even 400, is if your transferrin saturation is less than 20%, that you don't have enough iron circulating in your body because it's not released. We'll mention the mechanism maybe later on. So iron deficiency, absolute, less than 100, you got iron deficiency, or less than 300, or even 400 ferritin with transferrin saturation less than 20%. This is definition standard, accepted, adapted in all the studies. So basically in heart failure, you could either be losing blood, or you're not eating enough, and that will be absolute iron deficiency. But also because you have a chronic heart failure, your inflammatory markers goes up, the cytokines, interleukin, etc. And apparently, these lead to release of a hormone called hepcidin from the liver. So that hepcidin actually is what it does. It goes to your intestine and stop you absorbing iron. So it makes you things worse. So you become actually more towards the even absolute iron deficiency. You get less absorption of iron because this hepcidin that's released as part of the chronic inflammatory thing stop you absorbing or reduce your absorption of iron. Also, the hepcidin goes to your main storage part of your ferritin, the macrophage and the liver, and stop them releasing the ferritin from there. So the ferritin be stuck there and not released. And that's what's called the functional iron deficiency. So in chronic heart failure, you get absolute, you can get either or both, absolute iron deficiency, where your certain ferritin is low, or functional iron deficiency, where you have enough ferritin, but it's not circulating, manifested or tested by low transferrin saturation. Okay? So this is a question. I know you've done the polling question. Do you know how common iron deficiency in patients admitted with acute decompensated heart failure? So a patient came admitted to your department with acute heart failure. Do you know how many of them will have iron deficiency? You think it's 20%, 30%, 50%, or 80%. You may not believe this, but actually in chronic heart failure, iron deficiency present in up to 55%. In patients admitted with acute decompensated heart failure, the iron deficiency present in up to 83%. They almost all have iron deficiency. We test them routinely, and we give almost a lot of them carboxymethyl during hospitalization. So it's really quite common if you test for it the way as we mentioned. Look for the functional, but you have to test by measuring serum ferritin and measuring serum transferrin saturation. Or you can say, so what? They have iron deficiency. It doesn't matter. I mean, they are not anemic. Their hemoglobin is 12. So it doesn't matter. How does that affect the heart failure? Now, I need to highlight to you just another thing that I was not even myself aware of and become more aware of since we have been dealing with anemia and iron deficiency and heart failure. That iron is not only as part of the hemoglobin that transfers oxygen to the rest of your body, which is quite an important thing, but actually it's quite essential in the function of your mitochondria. Without your iron, your Krebs cycle doesn't work. Don't ask me about Krebs cycle. I remember from that top. But anyway, so that's where you form your ATP. So you have actually less energy. If you have less iron, your mitochondria doesn't function well. You don't produce enough ATP. You have less energy. You feel weak, tired, fatigued. You cannot function. It's nothing even regardless or independent of the effect of transferring oxygen around the body by the hemoglobin. So you got a peripheral effect as well as the effect of carrying oxygen. Just remember this, it's very important. So iron deficiency, you can either have low hemoglobin concentration, you can decrease your oxygen delivery, or you get the mitochondria doesn't work very well, you don't produce enough ATP, your energy is low. And in both situations, your peak oxygen uptake, which is a measure of your exercise capacity. So when you exercise, if you measure how much oxygen you take in, is affected by this. So if you really have a good lung, good heart, good hemoglobin, you're not anemic, you take a lot of oxygen when you exercise with less respiratory effort. So your peak oxygen uptake is reduced if you are either anemic or even just have iron deficiency on itself. And if you are not anemic and you have normal not iron deficient, your peak oxygen uptake on the left side bar is the highest, the best. So when you exercise, your oxygen uptake is maximum, and on the right side, the smallest bar, where you're not iron deficient, you're not anemic, your ventilatory response is less. So you get most oxygen with less respiratory effort. Sorry, but if you're just anemic, so second bar on the left there, if you are anemic but not iron deficient, yes, your oxygen uptake is less and your respiratory effort is more. But guess what? If you are iron deficient and even you're not anemic, you do worse than even those who are anemic but not iron deficient, if you see what I mean. And you do much worse if you have both. If you have hemoglobin, it's 9 or 10, and you are iron deficient, you do worse. So your peak oxygen uptake is less, and your respiratory effort on the right side is highest. So and so what? So basically, if you are iron deficient, when you have heart failure, you're less likely to have stable heart failure. You're more likely, the blue bars, you're more likely to be hospitalized. You're more likely to have worsening heart failure. You are more likely to have reduction in your physical activity. So iron deficiency has impact on your quality of life, but not only quality of life. You're actually more likely to die if you are iron deficient and have heart failure than if you're not iron deficient, even if you're not anemic. Remember this. It's really important, iron deficient. And all the measures are relevant. So if you have a low saturation, transferrin saturation, you do worse if it's less than 20% than if you have transferrin saturation more than 20%. You do worse if you have less serum iron less than 13 compared to more than 13. You do worse if your ferritin is less than 100 compared to more than 100. This is worse when I say worse, I mean mortality. I'm not talking about just worse, feeling tired, or it's really worse. And iron deficiency is quite important. Whether worse if you're anemic, but even if you're not anemic. So how do we manage it? Okay, this iron deficiency is important, whether without anemia, we know how to measure it. How do we manage it? Look at this. You think that maybe it's not a relevant topic, what he's talking about, maybe it's 1 or 2 studies and we are questionable. These are the tip of the iceberg. Just in the last 2 decades, see how many studies more than 12 or 13, whatever studies using various agents, were mostly IV iron, but also oral iron, erythrobiotin, etc. So many trials for the last 2 decades. You can say, well, let's wait until we become very anemic, we give them blood transfusion. That's not a good idea, is it really? I mean, you're not going to bring every patient every time with their hemoglobin is like 8, and you can use for acute situations, fine, but you cannot use it long term because it's bad. It gives you infection, immunocompression, volume of load, iron of load, etc., plus the logistic. And there's no evidence actually it's actually beneficial, neither quality or quality of life or morbidity or mortality. Okay, what about oral iron? We just give them iron tablet and that's it. Unfortunately, that doesn't work. It's been studied. It does not work. It doesn't affect your quality of life, morbidity, or mortality, partly because it's poorly absorbed orally. And also, even if absorbed orally, we know there's the issue of inability to release iron from the storage. If you have it in your macrophage, your liver, whatever, it doesn't get released. So that's why it doesn't work, basically. Oral iron does not work in iron deficient heart failure. Okay, let's give them erythrobiotin, subcutaneous injection. We know that erythrobiotin actually is low in people with heart failure. We know that actually low erythrobiotin level in heart failure with poor prognosis. There were so many trials looked into this. And the largest is this one that's looked into, studied 2,000 patients with anemia, give them this erythrobiotin called Therapeutic, whatever, alpha subcutaneously. And it did actually improve the hemoglobin. Hemoglobin actually got much better. But it made no difference in their outcome, whether it is admission, mortality, morbidity, nothing. It made no difference. Not only that, it actually was associated with more harm. There were more cases of thromboembolism with erythrobiotin. And actually now it's class 3 recommendation, i.e. you should not use erythrobiotin for people with heart failure. It's class 3, don't do it. Okay, then we have this now, the agent, the IV iron. These are the things that works. So this IV iron basically mostly it's a complex of iron core surrounded by carbohydrate complex given intravenously, and basically gives the iron straight to the tissue. And one of the first agents studied called iron sucrose, still available, used in pregnancy. The slight problem with this agent that you cannot give it in only small volume, maximum 300 milligram at a time. So you have to give it so many times, so frequently to keep the iron up. But it's been studied in a small study, this study called Deficiency heart failure, and it showed improved all measures of quality of life. So it does make feel patient better, walk better, global system better, self-score better. And just to highlight this point about this mitochondria thing, this study called Deficiency heart failure 2, basically what they did, they gave another agent called iron isomaltoside, again iron carbohydrate complex, was single shot people with heart failure with anemia. And what they measure something called phosphocreatinase recovery time. So apparently this is tells you how good is your mitochondria. So if it goes up, then your mitochondria working better. And they find when you give this agent, even single shot, that level goes higher, means that your mitochondria works better. So the skeletal muscles, energy get better. So even your muscle periphery get better. So you can do more, not necessarily just the heart is getting better. So what about the effect of this agents on the, again, quality of life, 6 minutes walk, which we do a lot of in NEHA class. The agent I'm going to speak to a little bit more about is the ferric carboxyl, the most studied recently. And actually it's a larger molecule, again with the ferric hydroxide molecule in the core surrounded by carboxyl. Now this agent, first, it is safe, it has no immunogenic potential, but also can be given in large dose up to 1,000 milligram iron over a short period, minimum 50 minutes. We give it over 30 minutes. We find actually maybe better or safer, whatever, that's what we have to use it. But you can give up to 1,000 milligrams compared to the only 200 or 300 with the iron sucrose. Now, one of the most well-known randomized trial in iron deficiency in the past, early 2009, is this called FAIR heart failure trial. Again, just randomized patient with iron deficiency, heart failure with reduced ejection factors than 45 or 40%. Again, the definition of iron deficiency exactly as we said before, so I'm not going to repeat it. That's for all the studies. And they give ferric carboxamol that's actually at a 200 milligram doses every 4 weeks. And basically, they found it improves all the quality of life measures, the NIHA class, the global assessment, 6 minutes walk, the KCCQ score, etc. And the benefit was seen both in the patient with anemic and those without anemia. They all have iron deficiency, but even iron deficiency without anemia benefit, iron deficiency with anemia do benefit. So both benefit. So that's for patients that they are symptomatic and in the street, you see them in the clinic, and if you give them ferric carboxymatose, the quality of life improves. What about those who get admitted to hospital, where we said 83% of them have iron deficiency? Does giving IV iron during hospitalization benefit these people? This was studied in the was shown actually. Sorry, this is not the admission. No, this is the one before. I'm sorry. So I'm trying to show you before the firm acute heart failure. This study looked at whether actually giving IV carboxymatose to symptomatic heart failure in the clinic, not admitted, does it reduce hospitalization? And this was studied in the confirmed heart failure trial. Again, the same setup of 300 patients iron deficient symptomatic heart failure class 2 to 3. Hemoglobin up to 15. Look, hemoglobin up to 15. So not anemic. People are not anemic by definition. Okay, and basically the primary endpoint, that significant improvement in the 6 minutes walk, which is again quite important measure of quality of life, but a secondary endpoint, significant reduction of hospitalization. So that was one of the first signs that giving this agent can reduce hospitalization. Then it was taken into the other study, which I just hinted to, which is the acute heart failure trial, which basically looked into patients admitted with acute decompensated heart failure, where iron deficiency anemia is quite common. Does giving IV iron help these people? Does it make any difference? So this study, again, enrolled patients admitted with acute decompensated heart failure with ejection fraction up to 50%. So now we're going into the HFmREF, not only just HFrEF. Okay, so and hemoglobin of up to 15. Again, as long as they are iron deficient by the definition we mentioned before, then they get randomized to either placebo or ferric carboxymatose, follow up for a year. Now, always the primary endpoint for most of the heart failure studies, total heart failure hospitalization and cardiovascular death. There is a lot of measured secondary endpoints. Now, the regime they use, if I summarize it to you, just simply, if they give 1,000 milligram during admission, they give 500 milligram, depends on the weight, the hemoglobin, they 500 milligram at 6 weeks, and then at 12 and 24 weeks, they give them 500 if they are still iron deficient by the measurement. So 1,000 during hospitalization before discharge, and we do that. And then you give them 6 weeks. Now, I will come to the standardization. There's no clear standardization of the protocol, how you give IV carboxymatose, but this study, that's the protocol they use. So 0, pre-discharge, 6 weeks, and then so from 6 to 12 and 24 weeks if they are still iron deficient. Now, mean ejection fraction was 30.2%. Half the patients were ischemic and half were non-ischemic, basically. And half were not even anemic. Half of them did not have anemia, just have iron deficiency, but not anemia. Now, this study, the firm acute heart failure study and the Ironman study we'll come to in a minute, they both were hit by the COVID, as you know, which affected the enrollment, the follow-up, the giving of the treatment. And we'll come to that because we did basically analysis based on all the patients, intention to treat, and then analysis based on the COVID sensitive analysis. So in this study, like 80% had at least 1 or 2 doses of carboxymatose. So it could, so maybe more would have more if we did not have the COVID. But still, as looking at the whole population of the studies, people who had ferric carboxymatose, the serum ferritin improved compared to placebo, and their serum transfer saturation improved compared to placebo. And there was a reduction in the primary endpoint of cardiovascular death, heart failure, hospitalization, but that did not reach statistical significance. But there was a significant reduction in the risk of readmission to hospital with heart failure. And there was no difference in death. But the study was only followed for 1 year. But when they did what they call COVID sensitivity analysis, looked at the patient actually, if they looked at the patient who had finished the whole protocol, get all the treatment as per protocol, there actually was significant reduction even in the primary endpoint with cardiovascular death, heart failure hospitalization, as well as the reduction of the heart failure hospitalization. And there was no adverse difference in adverse effects across all board, whether it's major or minor, even the articular, there was no difference between the two groups. There were more people having hypophosphatemia who had carboxymatose, but that tends to be transient with no major adverse event related to that. So that study was for 1 year. So the Ironman study tried to look into what about after 1 year? Should we continue or just give it 1 or 2 doses during that year and that's it? So the Ironman study would look into the use of IV iron long-term, more than 1 year, safety and benefit. And recruited patient admitted, either admitted or recent admission or stable but symptomatic. And they use a different agent called ferric derismomaltose. With slight, again, similar to ferric carboxymatose, a slight difference. This can be given even to a bigger dose, up to 2,000 milligrams. You can give at one time, and you can give it more rapid. But that's not the difference. But the study had a mean follow-up of 2.7 years. It was all done in the UK. They recruited patient with ejection fraction up to 45%. Again, HFrEF, slightly HFmrEF, either admitted or recent admission or have a heart failure with risk BNP. Now they use a lower cutoff of hemoglobin, up to 13 in women and up to 14 in men. And again, randomizing to either placebo or the ferric derismomaltose. Now the regime they use dose 0, and then redose at 4 weeks, and then after that, every 4 months they check the iron states, and they are deficient. They give them more. So 0, 4 weeks, 4 months. The other study was 0, 6 weeks, then 12, 14 weeks. Again, primary endpoint, cardiovascular death, heart failure, hospitalization. The study was slow recruitment between 2016 and 2021, and finished in April 2022. Again, this is the spread of the patient, inpatient, recent hospitalization, or stable, so we call stable heart failure, we want to call it that way. It can be either ischemic or non-ischemic. Now, again, this was hit badly by the COVID as well, but at least up to 98% received at least 1 dose, but some did not receive second dose, no follow-up, things like that. Again, when they looked at the whole population, because intention to treat whether they managed to complete the follow-up or not, there was reduction in the cardiovascular death, heart failure, hospitalization, but again, did not reach statistical significance, did not. And or even the heart failure, hospitalization, death, or there was numerical difference, but did not reach statistical significance. But again, when they used COVID sensitivity analysis, looked at the people who complete the whole protocol, that the primary endpoint was positive with significant reduction in cardiovascular death or heart failure, hospitalization. And there was no safety concern similar. So this paper, which is published this year, look at the meta-analysis of all the trials that use IV iron and iron deficiency anemia. And they looked into 10 randomized controlled trials involving more than 3,000 patients, including the Ironman study and the AFFIRM heart failure trial. And basically the conclusion of the paper that given IV iron to heart failure patients with iron deficiency, give you 25% reduction in the primary endpoint heart failure, hospitalization, and cardiovascular death. It's quite significant. So what the current guidelines tells us about use of IV iron in iron deficiency. Now the American was slightly softer. Basically they said class 2A, so you may consider intravenous iron replacement in heart failure with iron deficiency anemia to improve the functional states and the quality of life, and that's it. And obviously they mentioned that erythropoietin should not be used. The European was really more details. First, it tells you class 1. Class 1 means you must screen your patient routinely, periodically, regularly for anemia using the criteria we mentioned, the serum ferritin and T-SAT. This is a class 1 recommendation. Class 2A means you you should consider patients who are symptomatic heart failure, you see them in clinic, whatever, have iron deficiency, ejection fraction less than 40%, you give them carboxyl maltose to improve their quality of life. And if they have been recently hospitalized with ejection fraction less than 50%, as with the firm heart failure trial, you should give them carboxyl maltose to reduce the risk of heart failure hospitalization. Okay, this is all was before the Ironman study. You know, the class of evidence recommendation goes higher the more trial you have. So these two guidelines were before the Ironman study. So if you have a patient, you know, heart failure is bad for you. It's a killer. It's a progressive disease. It's not a one-off thing that you treat and the patient goes away. Those who see in the clinic and tell I'm fine, they're not fine because they will progress sooner or later. So a progressive disease. So if they are in front of you, class 2 to 3, giving them ferric carboxyl maltose, they improve their quality of life. They'll be able to do more, function more, and potentially get less admission. Those who have been hospitalized with you, if you give them IV iron, you definitely reduce the risk of readmission to hospital. Readmission to hospital is a marker of forced prognosis, is a marker of death. So don't underestimate the benefit of reduction of heart failure hospitalization. There's an ongoing trial called the heart-fed trial. So again, using carboxyl maltose and heart failure with iron deficiency anemia, ejection fraction less than 40%, using similar definition, follow up for 12 months. I think they're here now trying to find out the regime, the standardized regime. And this regime, so it's a large study, 3,000, the results are not out yet. And they're using a regime which now most people use now. And, you know, me, myself, have been changing the way I'm using it. And mostly I use this. So I routinely prescribe 2 doses straight away. Dose 1,000 and 500, 1,000 take stat, 500 in a week or 2 times. And then, so this study is going to look into this. And then every 6 months, you check they are iron deficient, you give them carboxyl maltose or they are in the new agent. And again, the primary endpoint is the standard one, the heart failure cardiovascular. So the study is not, results not out. I think maybe over this year, I'm not sure. So finishing off, it's been too long. Finishing off, iron deficiency is very common, very common. Iron deficiency is not necessarily anemia. Remember this, there is absolute iron deficiency and the functional iron deficiency. So patient with hemoglobin 13, they could still be iron deficient. You have to check, you have to do your serum ferritin and serum transferrin saturation. It's common, it presents up to 55% patient with chronic heart failure, 83% patient with acute decompensated heart failure. Associated with higher mortality and morbidity. Don't underestimate the importance of iron deficiency. The benefit of replacement goes beyond just improving the oxygen carrying capacity. You work at the mitochondrial level. I mean, you see it. You give IV carboxyl maltose. You can say this is all anecdotal, it doesn't matter. But they should come back to you and say, I'm feeling great after that. Really, the majority, not all, but the majority feel great after IV. You can say it's psychological, but you do feel better. You can do more, you can do better. And there's evidence for that, it's not just anecdotal. So there's no rule of blood transfusion, oral iron, or long-term, and on the long-term management. And erythropoietin should not be used in heart failure. Only IV iron carbohydrate complexes has been shown to improve quality of life, reduce hospital admission. It's class 1 recommendation to screen routinely, periodically, regularly for iron deficiency heart failure. It's class 2A recommendation. You should consider to treat symptomatic heart failure, symptomatic heart failure with iron deficiency, ejection fraction less than 45%. As per the FERN trial, it's class 2A recommendation to screen and treat iron deficiency for people with ejection fraction less than 50%. The Ironman study has consolidated the evidence regarding the safety and the benefit of long-term management for iron deficiency. The ongoing trial, the heart-fed trial, hopefully it will consolidate this evidence further and hopefully will strengthen the class of recommendation or becomes even class 1 and standardize the way we give it. Now the question I ask, and actually I have to confess I do actually, that patient with HFpEF do benefit. And I screen, this is outside the, the talk, I screen iron deficiency who are symptomatic for iron deficiency and I treat them. Because I believe it works in the mitochondria. I know I believe it's there. Anyway, that's it. So,
دكتور محمد ما شاء الله للأمانة. I always personally صراحة enjoy your talk. I enjoyed the talk of the other heart failure colleagues, Dr. Salah Al-Badri, Dr. Mohamed Abdu. To be honest with you, always your lecture and other colleagues' lectures are always enjoyable. And I never missed a single one of them so far over the last maybe 2 years. Superb talk as always. And I always learn from your talk. And to be honest with you, the talk today, it was practice changing for me. As I told you before the talk, you have to convince me, and I would say, yes, you 100% you did, you convinced me already, although you don't need to do anything to convince me, as long as I said, you say you do it, then I have to take it for granted. So anyhow, ما نبيش ناخذ وقت أكثر من حقي. فدكتورة إلهام القذافي، يا ريت نسمع your feedback and your comments. دكتورة إلهام تقدري تعملي انميوت. لو الدكتورة إلهام مش جاهزة، دكتور محمد الهمالي. اتفضل دكتور محمد. لا دكتور محمد أعتقد عمل أيمن. دكتور محمد هو he is already co-host موجود الآن. تفضل دكتور محمد.
مشكور دكتور محمد for your valuable presentation. Today we stressed on points that is not commonly discussed about iron deficiency, and we understand the definition and the difference between anemia and iron deficiency, and difference between functional and absolute iron deficiency, and how we treat, and the role of iron deficiency in improvement of functional capacity and exercise tolerance and quality of life. And you analyze the consequences of the treatment. So we are happy today to learn from you.
شكرا دكتور محمد. دكتور إلهام الآن معنا متواجدة كذلك. دكتور إلهام ممكن تعطينا your comments about the topic.
السلام عليكم.
وعليكم السلام ورحمة الله.
أولا زي ما قال الدكتور منصور، محاضرات دكتور محمد مميزة جدا وما شاء الله يعني ربي يزيدك. عندي شوية نقاط طبعا بنقولهم إن احنا طبعا مدارين شوية دراسات في ال Triple University Hospital regarding anemia in heart failure. Okay. And we found out تقريبا ثلث البيشنتس متاعنا اللي راقدين في CCU due to acute heart failure كانوا anemic. تقريبا 25% of patients who died due to heart failure were anemic, and 13% of the cases of acute decompensated heart failure were anemic. Okay. In other study, we found that 32% or 33% of the female who came with heart failure, they were anemic. Okay. الحاجة الثانية بننبه عليها إن لما ديروا أنتم diagnosis of iron deficiency anemia as guidelines mentioned إن لازم نتأكدوا إن الفيريتين low. But be careful that we have another cause of low ferritin, and we have to treat the other causes of ferritin. We have to check whether the patient has malabsorption like celiac disease, like Crohn's, and so on. Okay, طبعا دكتور محمد الدراسات كلها اللي قالها تقريبا تتعلق بين between the iron deficiency anemia between HFrEF. لكن I found a study نشرت عام نول في 2022 في الجورنال of European Society of Cardiology في الهارت فيلير جورنال، لقوا إن في دراسة قالت إن there is a benefit even in HFrEF and even increase the systolic function of right ventricle. So it's not beneficial only in HFrEF. Okay. سؤال ثاني مهم جدا في ليبيا. في ليبيا الاي في فيريك كاربوكسي مالتوز مش موجود او موجود بقله. So هل نقدر نعوضوه ب oral treatment in heart failure I find meta-analysis نشرت عام نول في Elsevier journal قارنوا ما بين IV therapy وما بين oral therapy of iron. يقول إن oral therapy of iron did not influence or did not improve the 6 meter walk وما يأثرش في quality of life, لكن it decreased the rate of hospitalization of a patient with heart failure. هذه بالتأكيد بس من دكتور محمد. هل الأورال ثيرابي اللي موجود بكثرة في ليبيا ممكن يعوض الاي في كاربوكسي اي في ferric carboxymaltose or not in treating patient of iron deficiency of heart failure in the heart failure? And thank you.
شكرا دكتورة إلهام. دكتور محمد أعتقد السؤال موجه إليك. حتى لو كان أنا عارف أنت ذكرتها في الكونكلوجن قلت اي في ماهوش اورال بس does it at least replace partially or nothing at all? تفضل دكتور محمد.
Okay, and if you want to start with that, really, and we mentioned the oral iron replacement, it tends not to improve anemia. I'm sure those who actually have absolute anemia, their hemoglobin of 8, and you give them iron for 3 months and the hemoglobin to improve 12, that's absolutely almost certain these people will benefit. So yes, there is. But those that we mentioned, particularly those with functional anemia, they will not benefit. There's no way they will not benefit. This is functional. This is a release of the iron from the iron stored inside your body. You have enough iron, but it does not get released. So those people they will certainly will not benefit from oral iron. And you know, even those who are iron deficient, they have high heart failure, they are absolute iron deficiency. The absorption of oral iron is low. So yes, you can use it. Yes, those who are really anemic because of their blood loss, malabsorption, celiac, whatever, and you can improve their hemoglobin. I'm sure they will improve. So maybe there's a rule there. But the majority that we see in acute decompensated heart failure, actually their hemoglobin actually is fine. 12, 13. Actually, they have a functional iron deficiency. And those will not benefit from all. They will not benefit from anything but IV. You need a delivery mechanism. You need a delivery mechanism to take your iron straight to the tissue. And the only way is IV iron. And I think iron, and I inquired about this, and I know patient actually, they use, there's a carboxymaltose, maybe as Dr. Ham said, it's available, but limited. I'm not sure whether you have either, do you have IV ferric saccharose? It's been around for a long time, even though you have to give it that more frequently, smaller dose, but also that's an alternative. But the oral, I think, is only for those who actually probably absolute iron deficiency. Now talking about HFpEF, I told you, I practiced, even though it's not in the guidelines, I practiced. I look for those who are symptomatic. We don't show somebody actually doing very well. I don't think it's a rule for HFpEF. But those really struggling, and you know this is heart failure, and the hemoglobin is 12, 13, and they are clear iron deficient, I give them carboxymaltose. Because that's the theory that actually, again, they release the mitochondria, stuff like that. But still not in the guidelines. And you mentioned your patient, your studies, and I'm interested when you said anemia, what was your definition of anemia, or what sort of hemoglobin you're looking at? Because you said the percentage of patients with anemia, but not iron deficiency. I bet if you look for iron deficiency, the number would be much higher.
شكرا دكتور محمد. دكتور أيمن السمير
تفضل. ضيوف عيد بدري رئيسة منك.
لا لان الاكسبرت بانل انا حبيت نمشي بالاكسبرت بانل لان الاكسبرت بانل الثلاثه بعد الاكسبرت بانل نشوف
مش مشكله منصور خلي عادل، لكن عادل ما يعطيش اكثر من دقيقه لان ديما ياخذ وقت.
بس منصور خلي الاكسبرت بانل يكمل الاول بعدين we'll follow as long as you guys have time. I have
just wait for the expert panel. عندنا enough time الحمد لله. اليوم تمينا exactly sharp even before the time. دكتور أيمن وبعدين دكتور عادل إن شاء الله.
يلا بإذن الله.
شكرا لك دكتور منصور. بارك الله فيك دكتور محمد. Excellent presentation. I think he covered the main trial very nicely. And if to summarize what I heard from you, and iron deficiency is very common, right? At least half of the patient they have it. It has negative effect on the functional capacity of this patient, their quality of life. and also increase the risk of hospital admission and mortality. Also, what I'm hearing from you, those studies were mainly for HFrEF, heart failure with reduced ejection fraction. I think if not all the study included, the EF is less than 50%, majority were less than 40%. So we are talking about mainly HFrEF here. Like you said, and Dr. Ilham also pointed out, there's some data that could be beneficial treating those patients with HFpEF, but the majority of data we have is for HFrEF. The data is still not that strong. It's supportive. You know, it's even the study like the Ironman that shows there's no significant difference between the iron infusion for different agent like the dorsimomaltose compared to the other trial that they use the carboxymaltose, but still it's have a tendency or learning toward favorable outcome. The other thing also I am hearing from the study you're saying, and I think Dr. Ilham also this point, oral iron therapy is not effective mainly because of the issue with the absorption, and that was very nicely pointed out in your trial from the iron out heart failure, HF. So PO iron supplement is out. If you don't have IV, your iron supplement is not a replacement, because this is different than the classic iron deficiency anemia from bleeding you talked about, I think. Now, the main trial, I think, that you pointed out, and they led to guidelines to push up the iron treatment with mainly intravenous, not PO, it's an important point, was the confirmed heart failure, and that was outpatient, similar to the Ironman, and also the fair heart failure, that was also, I think, outpatient. The affirm acute heart failure was the main one, more, I think, 1,100 patient, 1,100, that was inpatient. This is main, I think, the difference between the major trial, the affirm acute heart failure, than the Ironman heart failure. And these two trials, the confirm heart failure, the affirm heart failure, confirm was outpatient and affirm was inpatient, and both they showed they don't affect the mortality, but both they decrease hospitalization for heart failure, and that's why the guidelines moved from class 2B to class 2A, like from you could to you would treat those patients with IV and with the carboxymaltose trial. Excellent presentation. I tried to summarize what I learned from you today, and thank you.
شكرا دكتور أيمن على مشاركتك طيبة. دكتور عادل ديوب تفضل.
السلام عليكم. Mohamed, منور as usual. Talk, and I agree with Mansour. This will be a practice changing. I think the reason why I attended because I'm having a big passion and interest in this area, because as a surgeon, as you guys all know, we hate bleeding and transfusion, because bleeding kills, anemia kills, blood transfusion kills, because we are stuck. No matter what we do, everything could lead to bad outcome. So I think our hospital in the last few years has come up with dedicated nurse practitioner who will be only targeting patient anemic before surgery. So that's a very interesting concept. I mean, there's always this pre-op optimization that you look after from multiple areas, but this is a nurse who's dedicating only to look after patient with anemia. Any patient comes to the pre-op clinic, she finds hemoglobin low, she phones the surgeon. And they run all these tests, iron, ferritin, iron store, this and that, and arrange for IV transfusion and stuff. So, and even more, I found use of IV iron, which was more important, because if you have a patient waiting for surgery for two, sometimes the waiting list, sometimes the patient waits for up to 10 days before his surgery. Giving IV iron actually could bring your IV or your hemoglobin a little bit higher, especially in those Jehovah's Witnesses and people who refuse transfusion. So I think IV iron, at least in the last 3-5 years, in our hospital has a huge shift toward treating, and most of my patients are their EF is below 50. So my group of patients that I operate on, they're included in your talk. And one thing, I think I'm the only surgeon in my group, whenever I see patient in the clinic as a stable patient, outpatient with a class 1-2 angina, with reduced EF or with even normal EF, I have an automatic prescription. It says oral iron, vitamin C 1 gram, and 1 grams of B12. I give it to all my patients. So they wait 4-6 weeks because our waiting list is not that long. And my main thing is here to try to replenish as much as I can and try to, these are elderly people, their hemoglobin could be, whether I don't have to wait for the result of the CBC. I just give it to them as a prescription, vitamin C 1 gram, B12, and iron pills, Ferromax or whatever. And I do agree also with the oral iron. Most of our patient goes home with oral iron. Oral iron is not very well tolerated. It does give them all sorts of side effects. A lot of my patients, they don't even finish 2 to 3 weeks after surgery. So I think the way to go, I think IV iron is going to be a game change in this field. And I think the only thing I would say in our society or our Western society is the cost. It's not covered, and there's a lot of limitation on as to whom to give it. I'm sure for Libya, it will be expensive. I'm not sure, Ilham, if you can comment on the cost, because here it's very expensive. Yeah, that's my 2 comments that I would like to share.
شكرا دكتور عادل. دكتور إلهام ممكن تشاركينا تشوف أو الدكتور محمد الهمالي يشوفون إيش الكوست في الآي في ايرون.
دكتور محمد.
I think it's not available. يعني حتى في كبرى الصيدليات في ليبيا في ذات الصواري ما عندهمش. ما نعرفش بقية الصيدليات فيه ولا لا، وكم حاجة ما عنديش فكرة والله.
تقريبا الجرعة $800 و $1000 هنا تقريبا حاجة. You're talking about few, يعني it's not يعني $50 or $40. It's very expensive. It's not cheap. Mohamed, what's your comment on the cost in Emirates?
Believe it or not, actually, I'm not exactly sure about the cost, but I obviously our patients are insured, but I always face issues with insurance company about it because they will tell me this patient is not anemic. But I just send them the evidence. I tell them they are as per the guidelines, they are anemic, they are in deficiency, and that because this, because that, and that's international guidelines say recommend using this. So
because if you combine it, also most of my patients will get IV iron and erythropoietin, and even erythropoietin is not cheap. So I think the problem here in the American, Canadian, European system is the cost. Whenever it comes to cost, but you also know transfusion cost. So I think that's why the hospital now dedicated a particular nurse to address, because 1 unit of blood is over $1,000 to process, between donation, storing it, transporting it. So I think most of the hospital now is moving toward, we want to prevent anemia. We want to optimize anemia before you're going for procedures. As you said, you want to prevent hospitalization. So addressing anemia with IV iron seems to be the smart way to go.
في الدكتور حافظ المرابط في الشات كتب قال ان السعر 125 ليبيان دينار في 500 ملغ دوز، وذكر الاسم البراند نيم اللي موجود في الشات للجميع. في دكتور محمود الفتوري كذلك بعث لي رساله وذكر ان كاربوكسي مالتوز الدوز تبعه almost $1,000 يعني ممكن في نورث امريكا. فإت ساوند لايك ايوه
عفوا منصور، كمل نقطة. عندي نقطة بنقولها هنا تعقيب على دكتور عادل والسؤال للدكتور محمد، لكن سالم آسف قطعت، تفضل.
لا تفضل، أنا خلصت بس حبيت نذكر الأرقام هذه وبعدين ناخذ أسئلة.
في few concept I think it's important. راهو iron deficiency regardless of presence of anemia has worse outcome. فit's so important انك انت يعني ما تربطش الايرون deficiency alone بالانيميا. You don't have to have الانيميا. هو الداتا showed ان once the patient when they have iron deficiency, okay, regardless حتى الEF حتى if EF is normal or reduced, it has associated with worse outcome. يعني you have low ferritin النمبر اللي يشوفهم. الحالة الثانية up to date.
أنا ماشي صح واحد.
لكن شوف
أنا صح أنا الغم فيهم كلهم.
لكن شوف ال up to date there is no clinical. غير تسمع up to date, there is no clinical studies showing that oral iron supplement or erythrobiotin infusion affect the outcome in patient with heart failure. طبعا this is a data, a study. Clinical practice something is different لأن احنا now evidence-based medicine, okay, but not everything. يعني في يعني expert consensus or experience, it has a play a role, but it's not a major. Like انت if you want to follow evidence-based medicine, الداتا available. دكتور محمد يمكن يأكد أو يضيف على المعلومة هذه إن الأورال ايرون supplement والإريثروبايوتين study اللي were done, it did not show benefit. قبل ما نختم دكتور محمد، أنا عندي لك سؤال بخصوص التي سات total transferrin saturation، لأن في randomized trial لقوا إن most patient who would benefit من الأيرون infusion اللي they have T-sat level less than 25. I would like to hear your يعني input على طبعا والexpert panel والحضور. شكرا.
And first, just comment on Dr. Ayman. طبعا the iron deficiency, as he said, really is independent of the anemia. Actually, the iron deficiency, patient iron deficient who are not anemic do much worse than those who are anemic but not iron deficient. If you see what I mean. So you can be anemic, but you're not iron deficiency, you don't do as good as if you're not anemic. But if you're iron deficient, even if you're not anemic, you do worse than those who have anemia but no iron deficiency. So iron deficiency is really the bad thing. Erythropoietin not only not beneficial, but it's harmful. Especially class 3 recommendation. You should not give erythropoietin to somebody who have heart failure with association with high thromboembolic. It's class 3. This is their guidelines. Your question about T-sats, the T-sat is important because I'll tell you what my problem with iron deficiency. Actually, people with chronic kidney disease, because they all have serum ferritin in the 1,000. They always have very serum ferritin. The highest serum ferritin I see actually in those who are CKD patient. And that's where I struggle. Again, the consensus here is to use the T-sats. As we mentioned before, the serum ferritin, first the acute phase reactant goes up. Secondly, you may still have a lot of your ferritin in your body, but it does not, it's still in your liver, still in your macrophage, it does not go into the circulation. It does not go to your mitochondria, so it's not released. And how you know that? By measuring the T-sats. You transfer in, the transfer is the protein that carries the iron inside your blood. If it is saturation low, means that there is a very low iron inside your system to go to your tissue. So the T-sat is the most important one in the iron deficiency, in diagnosing iron deficiency. So even to me, I tell you, my CKD patient, they will have a ferritin even 600, 700, 1,000. If I go by the guidelines, I will not even bother. But actually, I check their T-sat. If they're less than 20%, 24%, I give them IV iron. So the T-sats are very important for the reason I just mentioned. Thank you.
محمد عفوا عادل لان النقطه اللي في محمد في المرضى بتاع السي كي دي راو could be elevated iron ferritin level نتيجه الكرونيك ديزيز ستاتس انفلاماتوري وحتى اليوز اوف اي في erythropoietin. زي ما عارفين انتم في الهارت فيلر زي ما قال دكتور محمد erythropoietin is not just يعني beneficial, it's harmful. لكن في السي كي دي يعني it's recommended therapy. فهذه يمكن راو affect your ferritin level, so you don't rely on it as much compared to heart failure. شكرا.
Just sorry, that point, I mean, a lot of our heart failure patients actually are dialysis patients. Quite a lot. HFrEF and dialysis patients, and they all get erythropoietin. So I get and again, there is benefit there, so difficult to fight and say stop it, but I check their T-sat is low. I give them for a carboxymal dose regardless of whether they're on erythropoietin. But I know that's better for them for the heart failure.
Mohamed, I just want to clarify this story. This is a practice changing lecture. يعني أنت توا في erythropoietin combining it with IV iron, you will do it for the CKD patient, but not the other non-kidney patient. Is that correct?
Yeah, that's the my colleague nephrologist will be prescribing the erythropoietin for them, and I will give them the carboxymaltose. You can say,
yeah, but the erythropoietin, if we exclude the kidney patient, you would not recommend to use erythropoietin as a management of anemia with IV higher. Yeah.
بس خلينا نزيد نوضحها بس نسمعها من الدكتور محمد. يعني في الاند ستيج رينال ولا ادفانسد كدني ديسيز ستيج 5 ستيج 4 انت you agree with erythropoietin?
Yes, because that's for the kidneys, so
yeah.
You know, it's fine.
Just to clarify, to put it to rest at least, yeah.
No, definitely, I will not say don't stop it, but I will not use it.
Yeah, and it's a multidisciplinary. It's a multidisciplinary. The nephrologist will take care of that role, not a cardiologist. صح دكتور محمد. دكتور صلاح.
ايوه نبي نسمع من الدكتور صلاح البدري. دكتور صلاح.
السلام عليكم.
وعليكم السلام ورحمة الله.
والله excellent talk, Dr. Mohamed, and excellent discussion by all. Very comprehensive. يعني regarding the same point of TSAT, even in Ironman, the latest study, I think they depend more on TSAT because a lot of inflammatory, diseases are coming with and can confuse the diagnosis. TSAT, I think, is a good marker. But the problem of ferritin also, we should not, if it is very low, we are in say the group of heart failure will be like in above 50. So we should not overlook other serious diseases. Like, we give patient IV iron and he is enjoying better life quality and, less hospitalization. But we might get a trouble after getting a late diagnosis of colonic cancer, for example. And then the patient won't be happy if you just overlook the diagnosis. Probably if the ferritin is very low, we'll say like less than 30, we have either to look for stool for occult blood or refer for colonoscopy. As routine is above 50, you need to do a colonoscopy now. So it's important to give the iron or carboxymaltose or whatever for heart failure. But for this point also mentioned by Dr. Ilham, we should be aware that we might have more serious disease to look for before just giving treatment of symptomatic treatment.
Well, that's really great point, Dr. Salah. And I remember last year, I had a case, a lady came to see me. She is in her 60s with HFpEF and shortness of breath, hypoxia, and so on. She came with syncope after having a lunch in a local restaurant. On exam, أنا توقعت she already saw her primary care. She had the routine blood work was done. So she came with her friend and she looked pale, but she's white. People sometimes think, oh, she looks white, maybe very fair skin. So I said, you know what, instead of doing cardiac workup, let us check the hemoglobin. And the hemoglobin came maybe, I remember 6.5, and the ferritin was very low. So anyhow, I sent her for colonoscopy. So she came with syncope for cardiac workup, and she turned out to have colon cancer. So that's a case that I saw, I remember last year. So that's a really important point. Sometimes دايما أقول, we don't practice reflex medicine, just look at the root of the problem or find the main etiology. Where did the problem start? فشكرا دكتور صلاح, شكرا على النايس كومنتس. ممكن ناخذ أسئلة الأودينس الآن في مش نكونوا فير معهم. الدكتور رجب تلالة, الدكتور رجب دايما اكتف الصراحة ومشارك معنا, فسأل سؤال ممكن زي intellectual question نقول أنا. Is there any new medication against الهبسيدين؟ ما دام الهبسيدين is causing problem في chronic inflammation. دكتور محمد El-Harari, something you're aware of, medication against الهبسيدين.
No, I'm not aware of all what I know. This is a part of the chain. It's part of the inflammatory process, because it goes high because of the other cytokines interleukin going up. I'm not aware of any drug that you can use to reduce the effect of that. It's a good point. But just mentioning Dr. Rajab, I'm really interested because he brought you actually a picture of this carboxymaltose. He said available Libya called Ferentas. He actually brought a picture. He actually available in his pharmacy or wherever he got it. It's available there, and the cost according to him is very cheap, 150 dinar. I'm not sure it's it.
Yeah, it's very affordable. 125 دينار ليبي ممكن يعني قديش $25.
You have to know the source. You have to know the quality, my friend. When it comes to iron, you don't want to be injecting it to anybody. You have to know the source.
Yes. فيه الدكتور محمود الفتوري ذكر سؤال. على فكرة دكتور محمود الفتوري غير كيف طلع من الجروب وديما نتواصل معاه، فطلع منه هو دكتور محمود الفتوري كيف خلص البيدياتريك ريزيدنسي وبيعمل بيدياتريك كارديولوجي، وما شاء الله ماشي لستانفورد في كاليفورنيا، يعني هيبدأ بدأ في جولاي. فطرح سؤال، يعني سؤاله كان there are some studies suggesting SGLT2 receptor inhibitors improve anemia. Does that give an extra advantage when considering heart failure treatment option? دكتور محمد تفضل.
It increases the hematocrit, so we still don't know how this agent work. To be honest, maybe that's one of the mechanisms, but it does not improve the iron status. And they also, you get less hyperkalemia with the SGLT2 inhibitors. So the great agents, but I don't think they will replace, screening or treating iron deficiency. Whether it's part of maybe, yes.
Yes. بس صحيح، وهم اصلا احنا نعطوا فيهم لجميع الهارت فيلر كلاس الان. الدكتور محمد الهمالي، لو عندك اي تعليق اخر او كومنت.
I think regarding the anti-hepcidin agent, I think it is still in research because hepcidin play a very important role in functional iron deficiency anemia. It is a very big dilemma. I read it about that. Maybe it is still in research.
تمام، شكرا دكتور محمد. دكتورة إلهام، لو عندك تعليق أخير.
السلام عليكم. لا والله ما عنديش، يعني قبل ما نتكلم على الكوزز اوف elevated ferritin يعني، لكن الدكاترة ما شاء الله غطوها يعني. فاي ثينك في ليبيا ما زلنا بس مش معدلين هلبة على الفيريتين ليفل، يعني every patient admitted. حتى في الفايلز لما نجي نتفرج على الفايلز نتاع البيشنت اوف هارت فيلير في المستشفى نتاعنا، ما عندناش قليل وين نلقى بيشنت عنده فيريتين ليفل لاسباب ممكن متعلقه بالمستشفى، ما فيش، ممكن متعلقه بنا احنا كاطباء، نحن لا نتبع في الجايد لاينز للاسف يعني. فهذه نبي نحب نركز عليها، يعني المفروض every patient with heart failure we have to send his ferritin level, hemoglobin, iron, to know whether he has iron deficiency anemia or not.
صحيح.
That's it.
هي شكرا دكتورة إلهام، أنت طرحتي نقطة الآن مهمة. طبعا الأشياء هذه تحصل في كل مكان للأمانة. تو حتى في أمريكا في برنامج في الهارت فيلير بيشنت، عندنا مثلا في المستشفى هارت فيلير كوردينيتور، they will look and review the chart في حاجة اسمها زي الكواليتي امبروفمنت. لما يجيك هارت فيلير بيشنت وهيف ريف ريديوس ايجكشن فراكشن، في تشيك بوينتس مثلا، هل هم على الانترستو، هل هم على الالدكتون، هل هم على البيتا بلوكرز، هل هم على الاس جي ال تي ريسبتور انهبيتور، واي if not you have to document in your chart. فواحدة منها الفيرتين. وحتى الناس في بعض العلم او غير علم او شغل او بيزي يكون الانسان ديما الحالات بكثرة. فهذا الغرض من المحاضرات هذه للتذكير، وانا واحد من الناس الصراحه. محاضره اليوم كانت براكتس تشينجينج وناخذها في الحسبان، و I will change my practice. I don't apply it for example routinely for every single patient that I see before. فالغرض منها المحاضرات هذه تذكيريه وتعليميه وتوعويه وتغير مرات البراكتس للشخص. دكتور أيمن السمير، ممكن كلمه اخيره؟
هو في سؤال دكتور حافظ المرابط ممتاز صراحة، وعندي سؤال يمكن حيفتح موضوع باهي. لو كان دكتور حافظ كاتب is treatment guided by hemoglobin level or iron saturation. طبعا الستاديز اللي done there is a protocol على الانفيوجن standard والfrequency، لكن my understanding إن it's not the hemoglobin level, it's mainly the ferritin level with TSAT. This is the main one you aim for to replete. مش عارف لو قدر الاكسبرت panel دكتور محمد عندهم كومنت على النقطه هذه. بس excellent question. صح البريدم ديت لا how you follow up on them. يعني والاكسبلانيشن دكتور حافظ وكلام جميع، لان زي ما قلنا ان الايرون ديفيشنسي يعني you should separate it عن الايرون ديفيشنسي انيميا. يعني في الكونسبت بتاع الهارت فيلر، يعني انت كل حاجه put it in perspective. انت في المنظور انت مش treating الانيميا itself، انت treating الهارت فيلر، والايرون ثيرابي حتعتبرها كأن this is another treatment for heart failure mainly with reduced ejection fraction. فمش عارف لو حد من الاكسبيرت دكتور محمد يبي يعلق على الاكسلنت كويشن من دكتور حافظ.
Absolutely great question, and I agree totally. This is all the definition of iron deficiency anemia monitoring based on your serum ferritin and T-SATs. And I can tell you anecdotally that we see patients, and actually I give a lot of commitment, almost daily patients. But what I can tell you from anecdotal that I see patient majority feel better, much better quality of life. If you doctor, I'm feeling better. You can tell me you're not assessing it. You're right, but I'm happy to see my patient happy. But those patients will get better. Some they can be either anemic, and you can see the hemoglobin actually improve, shoots up. Okay, but some group anemic, the hemoglobin does not improve, but they still feel better. And some actually they were never anemic and they still feeling better. So that actually is not related to the level of hemoglobin. Even the benefit. I give carboxymaltose to half ref with bit of anemia based on the stats, whatever, and I see the measure hemoglobin gone from 10.5 to 11.5 or 12 or something like this, and they're feeling better. Some the hemoglobin 10.7 doesn't change, but they feel better. Some hemoglobin actually already 12, 13, and they feel better. So even the benefit is not related to the change in hemoglobin itself. Just like this anecdotal, don't have data on this.
دكتور محمد، أنا نبي سؤال دائما نحب نسأل الكارديولوجيست أسئلة زي هذه شوية هي فيها شوية مس وفيها شوية ضرب على القطوس معنا العروس، لكن يختلف. كوليسترول، ايرون، هلبة حاجة في أي دائما احنا نركزوا على drugs. Has there been any study comparing good iron-rich diet versus IV iron? لأن مشكلتنا احنا as to why أنت you went to that level على iron deficiency. يعني ما عندكش كانسر، ما عندكش blood loss source، ما عندكش كذا healthy. I see it in families, by the way. I see it in a lot of sisters or families, cousins يعيطوا لي يبعثوا لي في التحاليل الفرت بتاعي 2 4 1 عودت خذيت ايرون، تحس روحي تعبان 40 و35 سنه صغار في العمر. I think your talk is also applicable to even non-heart failure patient, non-cardiac patient.
معلش يا دكتور عادل، خلينا نعقب شويه. اغلبيه المرضى اللي بيكون عندهم لو فيرتين ويونغ بالذات في ميل بيكون عندهم سيلك ديسيز. سيلك ديسيز منتشر هلبة في ليبيا. فتوا بالنسبه للبروتوكول في الاندوسكوبي ديبارتمنت any patient came with a low ferritin, they have to do jejunal biopsy to see whether he has celiac disease or not.
Yeah, I think the question is it's very hard to commit somebody to a good diet, good rich diet. يعني تاكل حاجة خضراء، تاكل مش عارف إيش، تاخذ شوية لحمة، تاخذ شوية. يعني مشكلتنا إحنا إن we need بنعطيه ايرون مرة هذه، مرة بعد 6 شهور وبعد سنة. باهي هل في study موري إن في good diet versus IV iron؟
دكتور عادل معلش عفوا دكتور محمد، لو عندك تعقيب. دكتور عادل يحب الامثال الشعبيه، فنبي نجاوب على السؤال بحاجه شعبيه. المريض الهارت فيلر فيري كومبلكس ديزيز، يعني كأنه مثلا انت عندك موتور سياره ضاع خلاص فشل، مهما تجيب له احسن زيت في السيارات وتغير له الفلتر خلاص انت تتكلم على فيري كومبلكس ديزيز اند ستيج، الموتور تعبان. احنا راو لاكي اللاست 5 years باهي، يعني من البارادايم ترايل I think في 2016 اكثر من 5 years الارني والاس انهبيتور داروا ثوره في الفيلد. المرضى الهارت فيلر كانوا متعبين جدا، يعني اخطا كنا الدايوريتك تو ميك ذم فيل بيتر، الاوت كم تاعهم كان فيري باد. فراو الميديكيشن هذه دارت طفره رهيبه في الفيلد. ان يعني انت كم مره تعطي مريض دواء يجيك بعدها 2 3 يقول لك اي فيل بيتر، يعني هذا تلقاه مع الانترستو ومع الفرسيجا والجاريانز، المريض بروحه يقول لك I feel better، الدواء هذا يفرق معي. لكن الدايت الهيلثي دايت كويس ممتاز، لكن تتكلم انت مور فول بريفنشن، يعني مثلا
رابط I don't want to go back to the same spot، يعني بنقعد نجيبها كل 6 شهور نحكم فيه شو بندير له. عرفت كيف؟ هي it's not an easy fix، والدايت الريتش ان ايرون وكذا. وفي وضع ليبيا اعتقد ان حتى الهيلثي دايت is maybe expensive. We all know healthy diet is expensive. لكن I tell you there's also the same argument for diabetes. I know friends who been prescribed metformin glyburide واحد قالوا لهم no, I can fix my diabetes by weight, by exercise, but the percentage of people who can do this is very small. That's unfortunate. السؤال لك محمد إنه can this principle of IV iron be applicable to younger healthy people, or is it dangerous? Is it backed up by any evidence? Can we say a 42 years old cousin who calls me my iron is low, my T-sat is low, can I just go ahead and have a shot of IV iron?
Anecdotally, yes, you can, and it is done actually. And the IV sucrose is given to pregnant women with anemia. And I know just a friend of mine, his daughter, just here, found to be anemic, it's probably whatever, and he went like a quick fix. So he got her carboxymaltose. So yes.
دكتور محمد هو السؤال عادل بعد إذنكم. أعتقد مهم جدا to put it in perspective with treating heart failure. وانا I would love to hear الانبوت متاع حضرتك ودكتور منصور والاكسبرت بانل كلهم ودكتور صلاح بحكم انه هو heart failure specialist، ان التريتمنت of heart failure يعني it's not a single agent, it's يعني a combination therapy. زي ما نتكلم احنا على الكواد ثيرابي اللي هو الارني والبيتا بلوكر والاس دي 2 انهبيتور والام ار اي، يعني ما فيش يعني حتى study اللي اندارت in addition. يعني الارني لما نحط كان المرضى على البيتا بلوكر، فهمتني، الاس جي انهبيتور المرضى كانوا على البيتا بلوكر وكانوا على الارني. فهذا الايرون انفيوجن راهو هذا in addition to the other medication، مش as replacement. حتى مثلا European guidelines كانوا specific ان التريتمنت اوف الفيرس كاربوكسيمالتوز باهي ولا ان هو في symptomatic patient with heart failure. ساما جاك في الكلينيك قاعد يعني انت حاطه على الميديكال ثيرابي على الكواد و still having symptoms او صار له hospital admission. فاعتقد النقطه هذه مهمه to put in everything perspective is not separate، يعني مش بتاع تعطيه ايرون تم الموضوع، لا. المرضى هذم يعني زي ما قلنا في الترايل هذا اغلبيه الماجورتي البيشنت اللي هم هيف يعني should be on the quad therapy. شكرا.
هو وحتى البوينت بتاع اللايف ستايل اللي قال عادل we do this for everyone. So for the hypertensive, they're all obese, they're all you know syndrome X, whatever. So you do the lifestyle, but you know
that's salt.
It doesn't really work. You don't ignore it. You tell them to lose weight, do exercise, whatever. Refer them to dietitian, but you cannot say, "Well, I will do this, but I'm not going to give you whatever the appropriate drugs." And as far as the iron, it's not like you bring them every 6 months, because you are going to see them. I will see them minimum 3 months. I see my house patient minimum. They are good ones, 3 months. So when you see them, and every time I see them, I just do cocktail of blood. I just do it. I check the kidneys, check the cholesterol, check the liver, I check everything. This is a routine. And then if there are whatever is missing, whatever I need to fix, and I do my best. في دكتور صلاح بدري رفع يده.
تفضل دكتور صلاح، أنا اعتقدت الإيد مرفوعة من قبل بس تفضل.
Yeah, just yeah. I think the problem iron deficiency is part of heart failure pathology. And it's getting the cardiac asphyxia, low albumin, iron deficiency, all telling us that patient is progressing. And the IV iron, I think the guidelines will come as upgrade in the recommendations soon. I think that the question of Dr. Hafiz is very important. We are giving here in Doha IV carboxymaltose for almost a lot of patients. I mean, getting the criteria. We have in our clinic a short stay, and we are calling them to give it like as outpatient. The question was in my mind that what's the dose? Usually this is very important because I was like giving blindly 1,000, 1,500. You know, some patient will give them 750 if they are low weight, and then you know, there I found a equation called Ganuzzi by Italian scientist. It's an old equation, but I think it's used now. You can just Google it and put the hemoglobin, weight, and iron store, and we'll give you the required dose for this patient. You give it, and probably this is the requirement for his iron replenishment, and then you don't need to bother about the you know, repeating it. It's patient is symptomatic, unless the patient is symptomatic later on. So I think this equation will help in giving the correct dose. Sometimes we're giving a lower dose. That patient he's 40 kg or so we'll give 750, and he might need a higher dose. So this Ganuzzi equation can give us the correct dose for the heart failure patient who require IV iron.
I agree. I concur on that. Really, I agree on that. But I'm just again anecdotally. To be honest, most of the patients don't know about you, Salah. Most of the patients we give carboxymal tools. Actually, when we screen them subsequently, their SATs and ferritin actually are fine. They don't qualify for repeat. Once after the 2 dose, not single. Give the 2 dose. If you check them later on, majority they will not be iron deficient next time. Majority. So I don't know, what does that mean?
شكرا دكتور محمد. إذا كان ما فيش حد من الأودينس ولا من الإكسبرت بانل عنده أي تعليق آخر أو سؤال آخر، حنعطي الكلمة الأخيرة للدكتور محمد الحراري.
أنا عندي سؤال بس. Yeah, go ahead Ilham. Go ahead. Yeah.
معلش يا عادل. أوكي، عندي سؤال على البري هارت فيلير ستيج. هل في أي benefit of supposing that you have a patient with a pre heart failure stage and he came with iron deficiency anemia or iron deficiency, just iron deficiency. هل في any benefit of giving him IV iron therapy or not?
No, as we said, really, the study is all the symptomatic HFrEF patient plus 2 to 3. So it does not apply to the stage 1 or stage B.
حتى الميجرمنت الاوبجكتيفز انت تبي 6-minute walk test نيها improvement نيها symptoms. فمرات it's hard to measure the objective measurement or the improvement. I'm not sure how would you measure it. بس سؤال جميل الصراحة جدا. دكتور عادل.
سؤال للبراكتسنج كارديولوجيست اللي معي في الجروب. I see a lot of patients get referred to surgery anemic. المشكل إن how many of you guys when you see somebody severe aortic stenosis, 3 vessel disease, mitral valve, whatever, and you find like hemoglobin احنا نقوله انتم 10 احنا نقوله 111 أو 110 أو 95. How many of you will trigger investigation and referrals and make it a big deal? Like most of the patient, it seems to be unless I make once they hit my clinic, then I find his hemoglobin is 85. Why? Then I call the GI to scope and I call for blood work. In your practice, when you refer patients for surgery or apart from do you guys trigger something in your practice or you let the receiving physician to deal with these issues?
خلينا نكون أول من يجيب، لأن مرضاي أغلبيتهم they have valve heart disease وأغلبيتهم مفروض ينحطوا على الانتيكوجولانت. Any patient who have anemia مفروض I have to send him to gastroenterologist. بهي نفكر زمان في قصة هذه قاعدة نفكر فيها لتوا والبيشن قاعدة تعاني لتوا. مريضة كان عندها severe aortic stenosis and I sent her for a check before send her to surgeon. كان عندها أنيميا، كانت الهيموجلوبين بتاعها تقريبا 10 أو 9 حسب ما نفكر. they did for her colonoscopy and they say normal. فبعتها للسيرجن، السيرجن دار لها عملية. بعد العملية تقريبا ب 2 weeks she got acute intestinal obstruction. الكوز طبعا في acute intestinal obstruction طلع عندها كانسر كولون للاسف، وقاعده تعاني لتو البيشن. يعني كان طبعا عندها ميتاليك ايورتيك ريبليسمنت على الوارفرين وكانسر كولون، واخذت اكثر من ثيرابي كيموثيرابي، وكان عندها ميتاسيسز، فكانت تعاني لتو. فالرساله بتاعتي اني any patient with anemia مفروض ما تحولاش للكارديك سيرجن لعند ما تتاكد 100% من الكوز اوف انيميا and you have to treat it before sending your patient to cardiac surgeon.
بارك الله. يا ريت الكارديو تجي هنا مع الجماعه اللي عندي. والله
يجي اسمع حصل لي وظيفه في كندا ونجيكم عادي يعني.
This is exactly what المشكل إن it's not even in the note sometimes. It's not even mentioned. I have to dig into blood work. يعني the problem here become very subspecialized. كل واحد يدير يعني telescopic medicine. أنا درت كات السلام عليكم، راديال والسلام عليكم، أبرو درت إيكو شفت الإيكو السلام عليكم. لما يتلوح لك الحالة تلقى أنيميا وتلقى كرياتين شوية أب وتلقى كذا وتلقى باهي يا جماعة شنو قالوا لك؟ باهي شنو عارف؟ ما فيش. وراه مش أنيميا نقول لك 112 أو 13 أو 11 ونص، لا 85 يعني 8.5 79 وما فيش لا حس لا مس ولا في دوشة عليها بكل. عرفت كيف؟ من اللي يبدأ ينخص النيرس اللي specializing in optimizing pre-op. تبدأ هي الاي في ايرون، تبدأ هي كانت تبي اي في اريثروبويتين، وتبدأ هي الفولو اب وتقول لك ما تديراش بعد اسبوعين، اعطيني 6 اسابيع باش ندير لك اوبتمايزيشن و فأنا this is I think a good response from you Ilham that you should not be sending until you find out the cause of your anemia. You find the cause, then you treat it and then you go ahead. إلا لو طول patient don't wait يعني لو فيه urgency ولا unstable ولا كذا this is another thing.
دكتور
طبعا مش معناه معلش طبعا مش معناه كلامي معناه احنا نطبقه فيه بسهوله، لا يعني في صعوبه في الكوربريشن between us and between other doctors in gastroenterology. لكن هذا المفروض هيك يعني مفروض ما تبداش مريض او ما تبداش مريض على انتي كوجولانت لعند ما تتاكد ان ما عندهاش cause of يعني if he has anemia you have to know the cause. هل هو treatable or not treatable before start the patient on anticoagulant or send him to surgery.
هو دكتور الهام عندك صديقين في الموضوع هدايا، hematologist consult وGI consult، ما غيرهم ما يطلعش المريض لين ما تديريش اي plan for operating until تجيك الكونسلت note back from the GI scope up and down، ما فيش حاجه، مش عارف المريض بتاعك هل هذا full scope ولا لا. وبعدين الهيماتولوجيست كان if you plus or minus الهيماتولوجيست not in every case، لكن لو انت قال لك والله عندي بيبتيك ألسر، عندي كذا عندي ميلين ستول، عندي هذيك معناها خلاص. لكن these are two friends that we probably should have them on our back يعني في
صحيح دكتور عادل. دكتور إلهام أتفق معكم، يعني root of the problem find the root of the problem and move from there. دكتور محمد الحراري لضيق الوقت ناخذ الكلمة النهائية.
شيء بارك الله فيكم. Thank you very much. Really, I learned a lot just from this discussion. I learned a lot from preparing for this talk. So and I really appreciate the opportunity to talk about this. I mean, iron deficiency is very common. As you say, it is not always anemia. More than I showed you from the study, more than half of the patients with iron deficiency do not have anemia. Iron deficiency has great impact on the quality of life. You know, for the most patient, it doesn't matter when he's going to die, if you tell him, but I need to live better. I need to be able to do more. I need not to be in hospital. So if you can do that by correcting their iron deficiency, in addition to doing all the other things, you should really. Screening for iron deficiency is, as we said, you need the serum ferritin, you need the transferrin saturation. The treatment is only IV iron. It sounds that maybe you have the ferric carboxymaltose in Libya, and maybe you should invest in it. Maybe government has to, what they call it, to subsidize it, whatever. It's part of the effective therapy. On the long term, it actually pays off. If you prevent your patient being admitted, you really reduce the burden, the cost of the health service. That's it. Thank you.
شكرا دكتور محمد. في الختام مشكور جدا مرة ثانية دكتور محمد الحراري على المحاضرة الرائعة جدا. شكرا دكتور محمد الهمالي من مركز مصراتة للقلب، وألف مبروك مرة أخرى على افتتاح المركز السبت الماضي. شكرا دكتور إلهام من طرابلس ليبيا على مشاركتك معنا اليوم. شكرا دكتور أيمن السمير على مشاركتك وتواجدك طوال السنين السابقة هذه والجود انفايرمنت اللي كرييتد with the Libyan Cardiac Society. وشكرا دكتور عادل ديوب على مشاركتك ممثلا للكارديوتوراسيك سيرجري. شكرا دكتور صلاح البدري من هارت فيلير فيلد من قطر. وشكرا لدكتور حافظ، دكتور رجب تلالة على مشاركتكم بالأسئلة، دكتور محمود الفتوري كذلك. وشكرا لجميع الحضور على مشاركتنا اليوم. فالمحاضرة تكون مسجلة بإذن الله، للذي لم يتمكن من حضورها إن شاء الله يقدر يشاهدها على الليبيان كارديو سوسايتي ويب سايت. وإن شاء الله حنستمر في هذه المحاضرات، والسبت القادم بإذن الله عندنا محاضرة أخرى مع الدكتورة نادية السني AKG based discussion. فانتظرونا إن شاء الله السبت القادم على نفس التوقيت بإذن الله 8 مساء بتوقيت ليبيا. في الختام السلام عليكم ورحمة الله تعالى